This is a 68-year-old male that presented with symptoms of recent ischemia, and this is the diffusion MRI showing areas of recent restricted diffusion, recent infarction, with some older infarctions present, but basically in the right hemisphere. A lot of these new infarctions are hypoperfusion related infarctions. We do routine what we call stroke protocol to evaluate the intracranial and extracranial vessels, and as you can see here, the right carotid is missing. This is the left carotid. The right carotid here is missing. So it seems by MRI that there is a cutoff, an acute cutoff, abrupt occlusion of the carotid on the right side. And in the intracranial MR angiography, again, you see that this right carotid is not there, and you see that the left carotid is present. Now, when you see this kind of middle cerebral artery attenuated, small, and you don't see anything more proximal, it seems that this is consistent with an occluded vessel, although MRI could sometimes fool you by thinking that there is an occlusion on a 3D time of flight technique, while in reality it is near occlusion. It's not completely occluded. In this particular patient, we suspected that maybe this is not a complete occlusion, so we ended up doing a CT angiogram, and the CT angiogram in fact did not show an occluded vessel, but it showed that this is a near occlusion. And this is a CT angiogram which shows, as you can see here, a patent vessel. This is the tight, very tight stenosis, probably more than 90%. And then you see a very small attenuated vessel distally, but it is patent. So patency with the hypoperfusion, even though the patient did have a stroke, but still the area at risk is much more than the area that has been infarcted already. So we decided to do revascularization, or carotid stenting is actually what we use in our hospital. Endarterectomy could also be considered. We're not going to get into this discussion at this stage, but this is basically the the diagnostic angiogram. It shows how tight this stenosis is, very tight stenosis. I would call this more than 99%, almost occlusive. And in this particular case, when you have near occlusion, you have to do angioplasty before placing a protection device, because you cannot place this protection device through this area of stenosis. So what I do, usually I pass a wire through this area. As you can see here, it was very easy actually to pass this small wire through the area of the stenosis. And after that I do angioplasty with a small balloon, typically about 2 millimeter balloon, just to have it open enough for me to place a protection device. This is post angioplasty, the initial angioplasty. And then while this wire stays in place to maintain access through the true lumen, then I place a filter device, and then I place the stent, and then I do angioplasty post stenting. And after that we double check the appearance, and this is after the stenting. Very nice results. Recanalization of the vessel, almost completely normal caliber, and I double check whether there's any intracranial thromboembolic complications, and here luckily there was nothing over there.